There we go. Can you guys hear me now? Is that better? Thumbs up. Okay, I wonder how that happened. Always something new. David, can you also check your audio for me really quickly? So we're going to get started in just a moment, everybody.
Yep. Morning, Fran.
Awesome. Thank you. Good morning. All right, I think we're ready to get started. I'm so excited for today's guest speaker. Let's get going. I'm going to start recording. It's so great to see everybody today. We are super excited to have you here for our July Match Coalition meeting. Today's program is going to be phenomenal. We're going to be looking at a topic that we know is an extremely important one, but for which many people really don't have a lot of information. We're going to be looking and talking about the tribal and indigenous communities. And we're really excited for our special guest speaker. But before we get there, as we always do, we're just going to kind of bring up the agenda. Hopefully everybody can see it on my screen here. We are going to kick off with just a couple of announcements and some brief legislative updates before we get started. So with that, why don't we just go ahead and start with the announcements. From the Match Coalition, friendly reminder to everyone that this is the last meeting before our very much deserved break. We'll be taking a break for the month of August. So remember that August is our time out. It doesn't mean we're not behind the scenes working. So if there's some things that you'd like to bring to our attention, or perhaps some focus areas that you'd like to see for the latter months of the year, we please do bring those to our attention. And with that, I'd like to hand it over to anyone who may have any additional announcements that they'd like to share, anything happening local within your state or your organization that you'd like to share with the rest of the coalition. Okay. If not, without further ado, David, I'm going to pass it over to you to give a brief legislative update.
Sure. Thanks, Fran. Good morning, everyone. Busy time on the Hill as we head toward August recess and a number of important deadlines and programs that expire at the end of the fiscal year, September 30th. Some good news and some bad news. I'll start with the bad news. The bad news is that the House Appropriations Committee just released their FY24 Labor HHS funding bill, the appropriations bill, and it cuts a lot of money, $17 billion from the funding levels of FY23, including really large hits to CDC and NIH, including some big cuts to the maternal child health block grant program, eliminating the Healthy Start program within HRSA, and some pretty big cuts in the Office of Minority Health and the Office of Women's Health within the Office of the Secretary of HHS. It also eliminates ARC entirely. The big caveat is that it is not really based in reality in terms of what we can expect going forward for funding for these programs, but it does signal the House Appropriations Committees and the House leadership's starting point in negotiations with the Senate and the White House over fiscal year 24 funding levels, which the top line numbers that the House used are well below the numbers negotiated with the White House for the debt limit, which is another issue. Basically, what this all means is we're likely to see a continuing resolution before September 30th that would fund, likely to see a continuing resolution instead of a government shutdown. But this would just continue funding levels for every single agency at the FY23 levels, which based on the proposals by the House Appropriations Committee wouldn't necessarily be a bad thing. But it does signal that a number of programs could potentially be on the chopping block if negotiations are successful and the FY24 fiscal year 24 package is included. On the and I know that might be confusing, so I can stop for questions in a second. But on the positive side, the House Energy and Commerce Committee marked up 17 bills. They looked at and approved 17 bills, 2 of which are maternal health focused. One of them is the PREME Act, which stands for the Prematurity Research, Expansion, and Education for Mothers Who Deliver Infants Early Reauthorization Act. It's a reauthorization for 5 years of a bill that was originally signed into law in 2006 and reauthorized in 2018. This bill is largely focused on trying to prevent preterm births. And it reauthorizes programs within CDC. HRSA does a number of new studies on the cost, impacts, gaps in public health that could lead to preterm births. And it would also establish an entity within HHS to coordinate federal programs across the government related to preterm birth, infant mortality, and other adverse birth outcomes. This is a bill that's led by Congresswoman Anna Eshoo and Michael Burgess. And the other bill that they marked up is a bill that's led also by Dr. Burgess, the Preventing Maternal Deaths Reauthorization Act. This is a bill that was originally signed in 2018 or 2019, and it would reauthorize and strengthen federal support for the Maternal Mortality Review Committees, MMRCs, and reauthorize this for another 5 years, as well as add on some additional focus and requirements to strengthen those MMRCs. So, this is just the first step for both of these bills, which passed with bipartisan support. The original bills were signed into law with bipartisan support, and they passed out of the subcommittee with bipartisan support. This is really the biggest movement around maternal health legislation recently, but I also want to note that we expect the Tech to Save Moms Act, the telehealth and the digital health piece of the Black Maternal Health Momnibus Act to be introduced in the House by the end of the month as a bipartisan bill. It was introduced in the Senate as a bipartisan bill by Senator Menendez and Senator Sullivan. But the last 2 times it has been a purely Democrat supported bill in the House in 2020 and 2021. But this year we found 2 Republican co-sponsors. So we're very excited for that to be reintroduced. And that's really sort of one of the biggest advocacy vehicles for the Match Coalition. So when it is introduced, we'll send around a note, launch the Legislative Action Center grassroots campaigns and all that good stuff. But pretty big, exciting activity in the House, in addition to some less than positive news.
I think it's a lot for folks to process, David.
Yeah.
Okay. So let's open up for questions. And if I need to warm us up, I can do that. But does anyone have any questions they'd like to pose? You can put it into the chat if you'd like to, if that helps. Okay, so can we rewind for a second, David, and go back to what you were describing around the budgets and budget cuts and impacts to programs that include maternal and infant health, such as the Healthy Start program? Can you explain that once again? Is this like something that's being considered, or is this something that's actually happening?
So it is, yeah. So it's just being considered. Every year Congress needs to pass their appropriations bills that set new or different funding levels for every single agency and department and office and program, including a number of grant programs. If they don't, then there's a shutdown. More often than not, there's something that's called a continuing resolution, which essentially funds the government for, a period of time, a predetermined period of time at previous year levels, rather than an increase or a decrease, usually we oftentimes see a lot of increases. But so this is, it's very largely a messaging bill. It has a number of other, besides all of the funding cuts, which are extraordinary and takes us back to, the early 2000s levels for a number of these programs. It is largely a messaging bill and sort of seen as a non-starter, used as a negotiation starting point. But you never want to start negotiations at such a shocking level. So it's unlikely that any of these will be signed into law, but something resembling some of these cuts, at least for some of these programs, could happen.
Okay. All right. Hi, Elizabeth. Thanks for joining and thanks for your camera on. Would you like to add some comments to that?
Hi, Fran. I just wanted to let people know that this year in particular is one of the most confusing appropriation cycles that we're going to see. Usually Congress, as David said a minute ago, doesn't get all its appropriations bills passed and passes a CR. But this year, the debt ceiling agreement has put more pressure on Congress to get to agreement on the funding bills by January of this year, not the fiscal year, but January, because if they don't, there's a 1% across the board cut. And so we are going to see a lot of maneuvering between the House and the Senate over the next few months. And as David said, we shouldn't be too alarmed by these numbers because the House took the position of really severe cuts. And the Senate is agreeing to the debt ceiling numbers that they, reached agreement on back in May. So I want to make sure people aren't alarmed. We're probably at worst going to see 1% reductions.
Okay.
And we won't see the Senate numbers until around the 27th of this month.
That's right. But David, wouldn't you say it's unlikely they're going to reduce funding for maternal health care too severely? We've got some supporters even on the Republican side over in the Senate.
Yeah, we're probably not going to see drastic cuts like we're seeing in the House. Yes.
Wow. Okay, well, thank you for that clarity. 1% doesn't sound so bad.
That'll be across the board.
Yeah. Hi, Jeannie. Did you want to ask a question or just have it's okay to have your camera on, but I just want to make sure if you had a question you wanted to ask of David or Elizabeth regarding the legislative update. Okay. Anybody else have a question or comment they'd like to make regarding the update? Really appreciate you guys going back and explaining some of that for us because it's a little makes everybody a little nervous to hear cuts are coming and not understanding what those look like. But I guess we knew that you're right that some were going to cut, but perhaps we, living in a bubble, we thought that ours might be avoided because everybody's priority is their priority, right? So hopefully we won't see too much there. We're going to get started transitioning over to introduce today's guest speaker. I'm just going to sharing the agenda here really quickly. As I mentioned before, just really excited for today's presentation as we're going to be talking about eliminating barriers to quality maternal health care and empowering Indigenous and tribal communities through information exchange and community collaboration. Before we get started, I think it's really important that everyone humble themselves quite a bit because there is a tendency to think that we know about all of the peoples of this land and that we understand what the needs are, but the needs are diverse and complex. And while we all know some of the statistics, which we will be reminded of in just a moment, and for those who don't know, that information is going to be shared. Just what does the data look like from a morbidity and mortality perspective? What we have seen quite a bit of in the media has been where we have taken numbers and we sensationalize them by throwing them into headlines for articles because we want people to read our posts. And I'm really excited that we're able to, put those things aside and get down to really talking about what the dynamics are, what is really happening, and opening our eyes up to having a greater appreciation for truly what is and what makes for the beauty of the diversity and of this land and of the people of this land, and the things that we need to do to really truly ensure that everyone has access to highest quality care possible. So without further ado, it's my great honor to be able to introduce you to Crystal Schramm, who is with the Michigan Health Information Network Shared Services Organization. She'll share a little bit about herself as well as the organization she's with, but I did want to take a moment to make sure I pause and acknowledge the phenomenal work that she does as a subject matter expert within the area of health information exchange, as well as the leadership role that she takes on with the Health Information Management System Society. If you don't know that name, that's HIMSS, the acronym HIMSS. The work she does representing the Michigan chapter of HIMSS, as well as the work that she is involved in representing tribal communities on multiple committees, including those related to maternal and infant child health. So with that, Crystal, I'm going to pass it over to you, and thank you so much for being with us today.
Yeah, great. Thank you, Fran. I really should have you come introduce me at every other thing I do. That was an amazing introduction. I could not. Thank you so much. You're so kind. It's a pleasure to be here. Let me go ahead and share my screen and then I'll get started. Oh, it says I cannot share my screen while the other participant is sharing. Okay, there we go. All right, Fran, can you see that? Can we see that okay? Are we good?
We're still seeing the agenda, Crystal.
Yeah, there's an option under view options at the top that you can choose which screen to share, but maybe best if Fran could stop sharing her screen. Fran, if you can hear us, can you stop sharing your screen?
Yes, I'm trying to.
Oh,
It's for some reason, it's like my computer is having technical difficulties. Here we are. Okay, there you go. Thank you,
Okay.
Crystal, for your patience.
Awesome. Yeah, no worries. We've all been in that moment. Okay, how's that? Does that look good?
Yes.
Excellent. Thank you.
Awesome. Okay, so I have two screens, so I'm going to look at my screen. So I'm sorry if I'm not looking right directly at everybody. Hello, everyone. Ani Misquamashikikwe Nadijnagas. My name is Crystal Schramm. I'm also a Red Turtle Woman. And as Fran said, I work at the Michigan Health Information Network. It's also known as MIHIN, so I'll refer to it as that. I am a senior technical business analyst there, as well as a huge advocate for Native American engagement, as I'm Native American myself, and I go to tribal healthcare. And so I'm also, just a little bit of background on me, I am a descendant of the Little River Band tribe in Michigan of Ottawa Indians, and my family is also descendants of the Saginaw Chippewa tribe of Indians in Michigan and the Choctaw Nation of Oklahoma. So we kind of have a really good mixture of different Native American backgrounds in our families, and so we are well versed in it. So as I said, I work at MIHIN. And just a little bit of background about that. So it's the state designated entity for all health information exchange in the state of Michigan. So what does that mean? I think the best way to describe it, just in a general perspective, is I think about water and pipes that you need to get the water. Not everyone, but we should have access to water, and you don't see the pipes behind the scenes. You know, when you don't have access to water, when the system breaks, or you can't get it somehow. And I kind of think about that. That's kind of what we are. We're kind of the data pipes behind the scene. We move data back and forth between hospitals and healthcare providers and skilled nursing facilities and the state of Michigan. Millions and billions of messages a day, per second, every single day. And so it's one of those things you really don't know it's there unless you work directly with it, or it impacts you on patient care side, where suddenly something breaks and you're not getting the data that you need. So it's really one of those behind the scene things. And one of the reasons it's so significant is because, you know, obviously in a perfect world, we'd all want to be on the same electronic medical record system, but that's not going to happen. And so one of the ways that we overcome that challenge is by creating an infrastructure that can pass data back and forth and integrate between systems. That's what MyHIN does. We're able to integrate across any platform of an electronic medical record system and other systems to make sure that the data can be shared for patients at the point of care. And so that's one of our biggest things that we do. Like, for instance, we send messages if somebody gets discharged or admitted to a hospital and their primary care provider needs to know where they went, we let them know in real time. But we do that, like I said, millions of messages a day in real time. So each state has a health information network, but the way that it's made up is really different. So it just kind of varies. So some states have different approaches, but this is in the state of Michigan, we're the one that oversees all of it. So I'd like to transition kind of into why are we here today, right? I was here to come speaking on maternal health care for Indigenous peoples. And I was so thrilled to meet Fran and talk about this topic because I'm a mother of 3. I do have a daughter, and I have families that live on reservations, and I have lots of ancestors that lived on reservations, and they've had a lot of health disparities because of what's happened in the past over time to the Native American population. And as you can see from this statistic, we know that there is obviously an issue going on, and we know that Black women also have this issue. So it's not just Indigenous women, it's other cultures and other races. And so I think that that's something really important I want everyone to think about is well, I'm not just here, I'm not thinking, oh, I want to just fix everything for Indigenous women. It's maternal health care in general. And that's why I come from the MyHIN perspective, thinking about the data side. That's the way that I come to try to work on these huge challenges and barriers. This next slide breaks it down a little bit more into the race and ethnicity side, kind of as that non-Hispanic Hispanic lens. And I think that's really important because as the government tried to basically get rid of Native Americans over time, we've slowly our population has gone down, but we're still here and we're still present and we're still in the system. And so a lot of times on a demographics, you're multiracial, but maybe it's not captured correctly, or maybe you're listed as Native American in one system, but you're Caucasian or African American in another one. And so I think even the data collection itself, when we're giving these mortality rates, isn't really, it's really underrepresented, and it's more than what we're showing here. I think that you could argue that about any data, that there's probably more than what we're really gathering. But I think with Indigenous women, it's even more, because I think the history of the Native American population has suffered so much from, at one time, people didn't even want to say that they were Indian because they couldn't own land if they were Indian. So you have these generations who hid that. So I think over time, the statistics were not as accurate as they could have been. Now, obviously, these are more recent. So, now people are saying when they're Native American, but I still think some people probably don't always say that. Another issue I wanted to point out with this, really quick, is that something that I've read about and I've seen in the state of Michigan too, is that when they're looking at death certificates, they look at the maternal side, which obviously I understand that because it's the woman that's having the baby. But what happens when a non-Native woman is pregnant with a Native American child? I think that's not captured correctly either. I actually have that scenario in my family. I have a family member who is the father is Indian and the son of the mom, the mom is not Indian, and then they had a baby. But now, how do you capture any of the issues that happen with that child? Are they left out of the system? So just things like that. Those are things I think about when I'm looking at the data, because I love data, as you can tell. So taking a step back, one of the things that I really try to emphasize when I'm working with everyone in this awareness side is that there are 574 recognized, federally recognized tribes in the United States. And if you go back on those slides, all Native Americans are lumped into one category. That does not seem very accurate to me. I understand at the time why we did it. There was a reason. We didn't, in general, we tend to view it all as this one lump category, but it's really not. Every tribe is a sovereign nation. They have their own community. They have their own culture. They have their own customs. There are similarities, yes, but a tribe out west is not the same as a tribe, in Michigan. It's completely different. And so, but when you look at the data, it's all put into one. And so I think looking at this map is helpful too, because Indian Health Services, is the main overseer of many of the healthcare facilities across the United States. But if you look at Michigan, for instance, you don't see like any IHS facilities, and that's because a lot of them have chosen to privately run their own because they were dissatisfied with how IHS was running them. So that kind of explains why you see that kind of big gap there in the Midwest. But there are, in the Minnesota, Wisconsin, and Michigan region, there are still 36 tribal health centers. I think 2 of them up in that like Minnesota area are still IHS ran. But so this gives you, there's a ton of facilities, there's a ton of tribes, but even this picture doesn't even really show how the variety of them. So I just wanted to point that out because it is so vast and different across the country. So going back to the data and the races. So one of the things that you'll see in HL7 standards for when those messages get passed and forth, if a patient gets admitted or discharged, is there's certain race categories. And these are basically it. I mean, how do you capture if somebody's from a tribe in Michigan and doing these things? That's a bigger thing that's going to take years to do. But I'm looking at it from the lens of, right now, let's just get the data for the tribes and share it so the patients can actually get the care they need at the clinical point of care. So this is important, but right now, even just for the general perspective, I think I just want people to have awareness that there is an issue with the way the race is classified. FHIR, Fast Healthcare Interoperability, I think the R, I'm not forget what the R is. They did create a classification for sovereign nation where you could put the tribe you're affiliated with, but I mean, not everyone. It's going to take years to go from HL7 to FHIR. So, it's obviously people are thinking about it and we're moving towards that. But in the meantime, we still have to take care of our patients. We still have to take care of our pregnant women. And so we need to make sure that whatever data we can get is captured at least somewhat. So going back to that brings me to, so regardless of where you are, we want to make sure that the clinical care can be helped and understand the landscape of what tribe that patient belongs to. So we're really looking at, in the state of Michigan, we've kind of taken the approaches, I'm going to go tribe by tribe and I'm going to work with them individually and independently so I can learn and educate them on why health information exchange will be helpful for them and why it's okay for them to talk to us about their data and let them know that this is a good way for them to take care of those women that are moving in and out of the health system. So in Michigan, as I said, we have 12 federally recognized tribes. And the biggest challenges are they don't know where the patients are. They don't know where they're going. They're not getting results back for their patients. This was really highlighted during COVID. Or maybe a patient goes to a hospital. They don't have any affiliation with that hospital. They have no way to get that data. I mean, how often is a patient going to a hospital to get OB care? Probably a lot. And tribal patients go in and out of tribal and non-tribal facilities all the time, but their data does not move with them. That's a big problem. Anytime they get referred out, it's typically almost always a non-tribal facility. So now the referral, whether the referral gets hit or not is one thing, but then actually getting the data back on the referral to the primary care provider is a whole other thing. Add OB to that, well, that's even tougher. I did talk to one tribe in Michigan that said, yeah, we don't have any data on for when patients are in the OB. And that is really problematic to me. And I think that could really lead to really disparate maternal health care outcomes. So we're using the infrastructure that we have today built in Michigan to work with these tribes to get the data flowing. And we're starting at the basic level. We're working on getting them to submit immunization data. So it's very, very basic to start because not everyone has the resources, has the funding, has the infrastructure. And so we're slowly working with the tribes to help them understand it's okay for you to work with us. And you can trust that your data is secure because we are this huge entity and we have all of these security stringencies. So you know that it's okay. But I'm working very closely with these tribes. Each tribe has their own tribal council. Like there's lots of different stakeholders and politics involved with tribes that nobody really understands. And they're afraid to want to work with them because they don't know what to do because they want to treat them like any other healthcare facility. It's kind of like the VA, but it's bigger than that, because the VA has a separate system, but each tribe could have a separate system. So we're really working strategically across the state with tribes and helping them to work with us. And one of the tribes that we worked with is the Nottawasepi. And one of the things that they did was they started working on referrals. While this necessarily might not hit OB, I still think it's the same kind of concept. They've used it to track where the referrals were going for colonoscopies, and they were able to shorten the time that the colonoscopies needed to get done, and they were actually getting them done at a higher rate, and they were getting better success rates. But I think you could emulate the same process with OB referrals and getting that data from the hospitals. I mean, we already work with all the hospitals in the state of Michigan, and we have that data. So if you're able to if we work with the tribes and are able to connect with them, then we can make sure that the tribes get the hospital data when they're going in for those OB visits. So it's basically lining up the data with where the patient is going. So the takeaways really that I want people to walk away from this presentation and this discussion are that we need to understand we can't rebuild like tribal health information exchange. I mean, we have these legacy ginormous infrastructures in the United States. We have Indian Health Service that has their own electronic medical record system. We have health information exchanges within states. We have health information networks that are, that work across the state. But I think that we can utilize the current infrastructure that we have and add tribal data into that infrastructure, into the health ecosystem. And once we do that, we get them in there and they can start seeing that data. And then the other things that happen with maternal health care, like telehealth, remote patient monitoring, you can tack onto that because you've got them in the infrastructure and in the health ecosystem, because right now they've been left out. And we talk all the time across the nation about interoperability and being able to track patients, and they're moving it in and out of state lines, but these patients they're not even there. I mean, they're not even included. So getting them in is really the first step. And then understanding that there are differences between the tribes. I can talk about maternal health care in Michigan, and it's completely different. We don't have tribal hospitals in Michigan, but they have tribal hospitals in Oklahoma. So maybe they track their OB patients differently or more, maybe they're more successful. I'm not sure. I'd have to do a little bit more research on that. Or if you go down to some of the Southwestern area, there's still tribes there that don't have access to water, internet. The women have to drive hundreds of miles to go to visits. They might deliver in an ambulance on the side of the road. So understanding that the resources that each tribe and each section of the country need are completely different. And that is important. You know, I can't go somewhere where they don't have water and say, well, why don't you have this health information exchange? You know, that's a different, having resources and access to hospitals and care is a different need than getting the data moving. So I think it really depends on where you are in the country as to what the next step is. But no matter what, I really truly think interoperability in data can help mitigate many of these issues. And then to tack along onto that, working with key stakeholders. That's something that I have worked very hard in educating the state of Michigan, working with the Intertribal Council of Michigan, working across the border with Indian Health Service. They know of us working, getting the immunization data, working with the state of Michigan. So tying all those tentacles together to make sure that everyone knows why you're doing it and what's going on. And I did look up there were some examples of tribal programs that were interesting to help with that care piece. And in Michigan, they started the Native Healthy Start Family Spirit program. And then there's also a patient and community action board that I just joined that's focused on maternal health care across the state. California, I noticed they had an infant health initiative. So states are doing like little projects here and there and based on grant funding, but there's not really, and I don't think it's a one size fit all. I don't think you can boil the ocean, but I think that if we can think about it differently and tie it back to the data and who the patient is and work backwards, I think we have a better success chance. The other reason that the bullet 5 really ties well with what David was talking about, which is the appropriations funding. IHS has to go through appropriations every year. It's not a guaranteed line item in the budget. And those are the funding items that affect all of these things for the tribes. The referrals, because they have a separate referrals program, the resources they have to the hospitals, emergency medical care. So I'm really glad that I got to hear that part of what you talked about today, how it ties to maternal health care, because that funding piece is just, it's always something that affects everything. So I'm really pleased to be here to talk to this group. It sounds like this group is doing amazing things for maternal health care. And I want to continue to help be a voice for tribes in this group. And I'm open to questions and comments and feedback. So thank you.
Crystal, thank you so much. We greatly appreciate you presenting for us today and providing us such a wealth of knowledge just to kind of get things going. Everybody, as you are so inclined, please do put your questions in the chat window or feel free to turn on your cameras. To get us started and warmed up, I want to go back for a moment and maybe talk about opportunities. Sort of a little bit of what you described sort of highlights sort of the insular nature of the way that the tribal communities are set up. But do you see that perhaps that could be of benefit and maybe having the opportunity to create like the first universal patient record or other types of digitally, powered solutions that currently today don't exist on this land in the US?
Yeah, I think that anytime you can tie the data back to the patient, and I think with a tribal patient in particular, they really are moving in and out of tribal and non-tribal health facilities. They're moving in and out of a lot of facilities that don't tie electronically together. So I think if you were able to figure that out, once you add on, like you said, the other piece for the whole universal health record, where you could look at, their blood pressure or their doula care, things like that. I think that that's a really good way to go because, yes, I do think you would be able to do something along those lines.
So one of the things that we're seeing more of, right? It's not to say that postmortems weren't done in the past or aren't going to continue to be done. They're certainly done. This investigation, it happens when there is a loss. But there are now birth collaboratives that are looking more closely at the data. They're looking at it from operational efficiencies perspective, and they certainly are taking a second review of incidences that are occurring. Can you talk to us a little bit? And Valerie, thank you for bringing this question to us. Share with us maybe a little bit about how birth collaboratives are established, or are there birth collaboratives that exist within any of the tribal communities?
You know, I don't know specifically like each community. I do know that the National Indian, the NIH, I think it's the National Indian Health Board, the NIHB, I believe they do those kinds of review committees. But I don't know to what extent. I don't know how often. I don't know what data they're looking at. I mean, the other piece that makes it tricky, kind of like how we have the CDC here, right? Where we have the CDC gather data and they're trying to look at public health from this big perspective. Tribes, Indian Health Service actually has epidemiology centers in the country. There's actually 12 of them across the country. And I've actually worked with one of them that works in the Great Lakes, but what data are they collecting and how are they doing those reviews? I think that there's a lot of work to be done there. I think that the tribes themselves, and they've told me, like one tribe said, we have trouble doing population health in our own community. How do they look at those reviews themselves? I don't know what they're doing in there. So I think that there's a lot of questions that could be asked to further dig into more on what we could do to start uncovering ways to proceed with these things.
Mm-hmm. I want to bring, thank you, Valerie, for joining us. We'll have you to pose a question in just a moment. I want to bring in one hard one that made me a couple of people uncomfortable, but it's just, it's a reality, right? There's funding that's going towards doing things like establishing collaboratives and leveraging digital technologies. Crystal, you had referenced a few of those, which are, considering the distances between where people live and access to resources such as telehealth become really important. But with all of that, it seems that, folks follow the money, right? They're following the money trail and they're bringing their technologies or their consultancies into communities, for a lack of more eloquent words, taking advantage of the funding that's available. How do what have been some of the sentiments that you've heard? What are some of the things that vendors who or consultants who are really wanting to do good, what is a more appropriate way for them to get engaged, and how do we sort of reduce the amount of corruptedness or dishonesty that's happening when it comes to those who are out there bringing in their quote unquote solutions to tribal nations?
Yeah, that is such a great topic. There's a lot of tribal owned organizations. I know a lot of tribes really like working closely with those affiliated organizations, but from a technology perspective, I don't know how many, I think there are organizations that exist out there, but I do think that that's an issue. I know that there has been systems that have, marketed to tribes, and there are ones that try to do the one size fits all for grants, and then they get, the tribe gets left out to dry because they didn't get what they needed, and now they didn't get their grant fulfilled. So I think that is a really difficult area for tribes because they are already so wanting to trust, they're so scared to trust, those vendors. So I think we that work with vendors that work in the health IT space need to be aware that when you're talking to them, it's not about selling a product, it's about helping them see what value you're going to help their people with. And that's really, that's one of the things we do at MyHIN is that I say, we don't care who your EMR vendor is. We don't, we're not here to make it harder for you. We're trying to help you get those basic health equity needs. And I think if we go back to health equity and basic needs, that's what matters.
Mm-hmm. Absolutely. Valerie, thank you so much for coming on the camera. And I noticed that you had a question that you'd like to ask. So please ask your question.
So my question has to do with the increasing number of really sort of maternal health deserts that we've seen sort of increasing over the past 10, 15 years. And Crystal, I just wanted to know from your perspective as a representative of MyHIN as well, if or how tribes, IHS, partners, state, local partners like MyHIN, for instance, how are they working to address those gaps? And, how can data modernization efforts, as there's currently a big push towards modernization, how can that help with this crisis?
I think the data modernization effort is huge. I think that the system that IHS has run for years, the electronic medical record system, is ancient. And I think that has really impacted tribes negatively over the past. I think it's helped create those deserts. I think that's been part of the impact that has led up to it. And so I think the more that we can work with tribes as they're implementing that whatever EMR system is built, and working to integrate and work together with them. I think if we can do that and use that interoperability piece with it, I think we could do so much. I think about, working with the tribes. So, because we don't want to replace the same problem with the same problem. You can't just put a system in and say, oh, everything's fixed. No, let's utilize the system and build these issues into that as we're making those improvements down the road.
Great points. Thank you. Elizabeth, you'd like to ask a question?
Sure. I'll just follow up, Crystal, on what Valerie was asking. And during your presentation, you talked about the differences in the collection of the data, right? That some data sets have specifics with regard to the tribes and origination, and others don't. Is there something that could be done at a federal level from a policy perspective to encourage the universal collection of, similar data?
Ooh, that's a tough question.
Sorry.
That's okay.
Thinking of it, on a sort of a federal level, and what could we do?
I think if there was a way that we could give tribes, help them connect to interoperability, like help them be interoperable for one, because they have to have that connection. So once, it's one thing to convince them this is why you should do it, but kind of like, what's in it for them? How are they going to help their population? Once they get that interoperability, once they're able to see that data, that's great if the federal can see the data across the board. Let's say you could look at public health across and see, oh, this is great. But how is that community going to be able to utilize that system? How are they going to have a system that they can say, because I know this is what I've seen is one of the biggest areas that tribes really have so much work is they have to report so much because of everything that they have to do. So they have to report to IHS. They might have to report to the state of Michigan. They might have to report to their tribal board. But if we had a way that we could help make that reporting aggregation better for them, and for the other entities, I just think that would be amazing. I see that with immunizations, like right now in the state of Michigan, just the amount of reporting that they had to do during COVID. I mean, that's where my mind goes, I guess.
That's really interesting. I mean, what drives, I would think, and I need to be corrected if I need to be corrected. I would think that the only thing that drives the reporting of any data back to the U.S. federal government is based on the acceptance of funding from the U.S. government. Can you talk a little bit about, I think we sometimes forget that these are sovereign nations. Someone had asked the question in the chat, about maternal mortality. I'm looking up because I'm reading from the chat, the maternal mortality committees based on vital statistics and, that are run by every state. I think what we're forgetting is that when we look at Europe is a great land and it's all different countries make it up. Well, there are other countries or nations within this great land of the Americas as well. And so, Crystal, can you talk a little bit about how that translates into the independence, the autonomy, and the authority to make self-declaration on how much reporting should be done, who makes the decision on that reporting?
Yep. Yeah.
Committee reviews.
Yep.
Yeah.
So, yeah, I mean, each, like you said, each nation is a sovereign nation. They have to be able to work with Indian Health Service so they can get those funding dollars to be able to provide healthcare for their patients. And so they are expected to report back to the federal government, but they're giving the resources that they're given through the federal government for that is inadequate to help them do that reporting. So it's kind of this really tricky thing, because now they're struggling trying to get, have consultants come in or say, oh, we can help you with this piece of it, or, oh, we can help you with this piece. Oh, you need help reporting your maternal outcomes. We can help you with that. So I think that is a big reason why. And like you said, we're not like Europe, right? We're the only nation that I think Australia is another place I think of where they had original inhabitants and they're now incorporated into it. But the one state that has done the best really is Alaska, because they're a huge Native population. They've figured it out because they've had to. They have remote, people. So, but I think we are very challenged down here in the 48 states because we have such a variety. So I think that just being able to have the tribal world meet the federal and state world and come together, I think is key. And I think you have a lot of tribal people who are very have animosity because of the past and because they've been burned in the past. I mean, that's just the way it's been. And so, and it's hard for people that are not tribal to understand that and want to come together and come to the table. So I hope to help bridge that gap, because that gap has been continues to cause challenges and barriers.
We have just a couple of minutes before closing. And if are there any other questions? Because if not, I want to maybe pose one final question related to SDOH. Any other questions? So if I want to rewind for a moment, Crystal, because if I recall correctly, one of the things that you sort of described is how maternal health care, whether that's from an OB, but likely not from an OB, likely from a midwife or other maternal health care provider, is maybe outside of the clinics, right, themselves, and directly in community. And if we look at maternal mortality in general, there are maternity related and maternity associated complications that result in deaths. So these things may be, for example, postpartum depression, domestic violence, homicides, substance abuse, including alcoholism. Can you talk a little bit about the vision that you see for the Michigan Health Information Network and others within the tribal communities in particular that are focused on collection of data to address those gaps, and how is technology being leveraged or harnessed in order to equip those care providers who are outside of this quote unquote system to be able to contribute to the knowledge and information needed to put in place more comprehensive programs?
Great question. And I love that you brought SDOH up and talking about the person, because not everyone that's pregnant is pregnant their whole life, right? There's another person that's when you're not pregnant, and you could have depression, or it could develop during pregnancy. You could have food needs, you could have transportation needs, and we get SDOH data at MyHIN. And so there's probably a way to tie at some point that patient becomes pregnant and now you look back at their past, what were their SDOH needs over the past, however much time? Okay, we need to take that into consideration now that they're pregnant. Like, we need to really think about what other additional help and resources is that patient going to need, because now that they're at this different point in their life. And I think the SDOH piece could really tie to it. Heck, you could even have OB SDOH that's just specific to that during that time in their life, because I think that depression, for one, the depression, substance abuse, and the alcoholism and the behavioral health, I think those four, you could create some kind of OB SDOH data hub or something, you know what I mean? I can see it. And where you have certain data points that touch on those. I think if you could use that data to your advantage, and do it that way.
And how do we equip those who are providing the care, who are outside of the system, so to speak? I mean, they may not have the technology at hand, or do you see outreach programs that are being created to provide increased digital literacy and digital health literacy?
It's really interesting in the Native community. I've worked at a federally qualified health center before where we had community health workers. A lot of tribes actually have like that community aspect. So if you maybe look at the tribes that are using community health workers to their advantage, and maybe kind of look at that and emulate that program across other tribes, and have like an OB community, where you utilize that doula, and maybe they didn't get primary care and now they're pregnant and now they're going to go get care. How do you get them in the system? So utilizing those connections and resources, I think those key touch points, and recognizing how you can use those communication and relationship touch points to get them into the system. And I keep saying in the system, but I mean to track their data is what I mean when I say that.
I'm going to try to slip in one more 60-second question. The culmination of maternal health bills don't touch on many of the things that you're talking about, Crystal, in your final points here. How do we advocate? How would you say that we go about advocating for OB SDOH data collection? What would be some recommendations? And we'd love to hear from others as well who are participating on the call. Maybe you have the answer to that question. Any thoughts?
Yeah, feel free to chime in. I don't know that it's necessarily a whole new data collection, but there's all this emphasis on SDOH. And I think if you took that and looked at don't recreate something else, use the infrastructure we're already creating and figure out a way to tie it to those OB SDOH key components that you're wanting to look at. That's how I would approach it.
I love that suggestion. There's so much data that we have collected that just goes completely unutilized.
Yes.
We're not leveraging what we do have at our fingertips, and we have created much more flexible systems than we have in the past. Perhaps one of the things that we're just missing is having that Dewey Decimal System, so to speak, having that standard language created that we all can agree on. So that there's consistency and in the data, and the data can be as clean as possible for us to be able to interpret and start to apply in ways that are beneficial. Guys, this has been an amazing meeting today. Every third Tuesday is like the day that I am just always waiting for, because it's always incredible. And today is no exception. Crystal, we want to thank you so much for bringing such incredible knowledge and thoughtfulness to not only the work that you do, but to educating ourselves and many others on the needs of tribal nations, as well as the hard work that the Michigan Health Information Management Shared Services team is busy doing. Thank you so much for everything you do.
Thank you.
Yeah, thank you for joining us. All right, everybody, we won't see you in August. Have a fantastic summer. We will see you in September. Have a great rest of the day, everybody, and stay cool.
Bye, everyone.
Bye.